Right, we can start now. We will look at the third and the last part of this lecture series on receptors of spatial sensation. So here we are going to look at the eye and visual pathway. Well, there are also other things we are going to look at around the eye. Remember, we've already looked at the other four spatial sensations: taste, smell, hearing, and equilibrium. So our specific agenda would be first to describe the anatomy of the eye. In the process, we're also going to describe the structure of the retina. And then we look at how vision is transmitted from the retina to the cerebral cortex. We'll be highlighting and what unique things about that. We'll also take this opportunity to describe the extraocular musculature and how they move the eye, and also the lacrimal apparatus of the eye. So I'll try to be a little quick so that we finish this within good time. This is longer than the other that we've talked about. Just to start with, hoping that you know the names of the different parts, I'm giving you some 30 seconds to look at from number 1 to number 8 and just have an idea on what is what before I tell you what they are. 30 seconds you have. Okay, that should be it. So I hope the part level 1 is, you know, it's the upper eyelid, and that means that the other one is the lower eyelid. So the term palpebra refers to the eyelids. The gap between the upper eyelid and the lower eyelid, that gap is what we call the palpebral fissure. The gap between the upper eyelid and the lower eyelid. It can be open or closed. Right now it is open. The junction between the upper and the lower eyelids on the medial aspect is the medial canthus, and on the lateral aspect is the lateral canthus. The part level 5 is the sclera. That's the white opaque part of the eye. Then this diaphragmatic pigmented region is the iris, and that central part is the pupil. The limbus is here. It is a junction between the sclera and the cornea. So we call the corneoscleral junction. So there's something called the conjunctiva as well. We're not seeing conjunctiva at this point because the conjunctiva is a transparent mucous membrane. It's a transparent epithelial membrane. That transparent epithelial membrane covers the sclera, the outer part of the sclera. Then it reflects to cover the inside of the eyelids as well. For that reason, the conjunctiva is described to have 3 parts. The part of the conjunctiva that line the sclera is called the bulbar conjunctiva. The part of the conjunctiva that line the inside of the eyelids is called the palpebral conjunctiva. The junction between the two is what we call the fornix of the conjunctiva. So bulbar conjunctiva, palpebral conjunctiva, and conjunctival fornix, the junction between the two, usually on the upper part. Similarly, there's something called the cornea. The cornea is also transparent. You don't see it here because it is transparent, but it is the one that is covering both the iris and the pupil. So from there to there, we have the cornea. So that is with regard to this frontal anatomy of the eye. However, if you're asked to use a label diagram to illustrate the anatomy of the eye, we expect you to have such a thing drawn. This surgical anatomy of the eye is a better way of illustrating the anatomy of the eye. We describe the eye as having 3 histological layers. We call them the tunics of the eye. Tunica fibrosa, also called the corneoscleral layer, made up of cornea, sclera, and the limbus. So that is the sclera, that's the cornea, and that's the limbus. Tunica vascularis, made up of a heavily vascularized layer, that's what's called tunica vascularis, also called the uvea or the uveal tract, made up of choroid, ciliary body, and the iris. And then you have the retinal layer, the yellow one in this case. I want us to talk about these 3 tunics of the eye at greater detail. And so let's start with the tunica fibrosa. It's also called the fibrous coat of the eye. The fibrous coat of the eye is predominantly made up of fibrous connective tissue structures. Their role is to cover and therefore also to protect the structures which are inside the eye. They protect the intraocular structures. As I have indicated, it's made up of the sclera, the cornea, and the limbus. Let's start with the sclera. Sclera is the most posterior. It's the largest. It's opaque. It's white. It forms the insertion of extraocular muscles, so muscles attach onto the sclera. Other than that, we know that the sclera is continuous with the dura mater of the brain, the dura mater that is around the optic nerve. So posteriorly, it merges into that dura mater that covers the optic nerve. Anteriorly, it will be continuous, the cornea. And this is the part of the eye that we usually see as white when you look at someone's eyes, because the sclera comes much even anteriorly. Remember, it is still for protection. Cornea is this part here. Cornea is transparent. It is in front. And because of that transparency, it forms part of the refractive media of the eye. When you talk of refractive media of the eye, we are referring to the structures that bend light as light passes through the eye. Histologically, the cornea has 2 epithelial linings, one in front made up of stratified squamous keratinized epithelium. We call that the corneal epithelium. And another one behind, made up of simple squamous or simple columnar epithelium. We call that corneal endothelium. Between the 2 epithelial layers, a very thick layer of connective tissue, what we call the corneal stroma. Cornea is transparent, so it doesn't have blood vessels within it. It doesn't have pigmentations within it. It's very clear. The junction between the cornea and the sclera is the limbus, which is the corneoscleral junction. The function of the limbus is that it has some channels within it for drainage of the aqueous humor. The fluid from here enters like that through the channels within the limbus. So that is a fibrous coat. It's for protection, but each of the elements of the fibrous coat have other specific functions. Now we can talk about the second layer, the vascular coat. The vascular coat, also called tunica vascularis, uvea, or the uveal tract, is heavily pigmented and richly vascularized. Several blood vessels within this layer. This layer is also dark, heavily pigmented. It consists of 3 structures. From behind, That's the choroid layer. Then this is the ciliary body, and that is the iris. Let's start the choroid layer. So this choroid layer, as we've said, is heavily pigmented, is the most posterior part of the uveal tract, made up of loose connective tissue and several vascular channels within it. This image here captured for us that anatomy of the choroid. This is the choroid layer, this one here. So you see some large vascular channels because it's heavily vascularized, but you also see heavy pigmentation there. And that one, that's the choroid layer. This is the retina, and that's the sclera. This is optic nerve entering the retina. Because of the heavy vascularization, we can say that the choroid offers nutritional support to the retina that's adjacent to it. Because of the heavy pigmentation, we need to note that the pigmentation helps to absorb light. The light being absorbed by the choroid is not the light that is useful in vision. If light enters the eye, it will go through the retina first. And so by the time it's going to the choroid, it has already been detected for vision. That light that lands in the choroid or may land in the choroid is supposed to be absorbed so that it does not reflect. Because if it reflects, it will give you multiple image formation within the eye. The brain will construct that as multiple images. You can imagine if you enter a salon or a kinyozi and they have mirrors all over the wall. So you enter, then when you are seated, you see your image in almost all the walls. You wonder how many are you? It's because of the multiple internal reflections. So that is avoided in the eye. And that is why the choroid, as well as some part of the retina, is heavily pigmented. The second component of the vascular coat is the ciliary body. So this is the ciliary body there. The ciliary body is lined by ciliary epithelium, and ciliary epithelium is heavily pigmented, as you can see in this region. We can see that heavily pigmented epithelium with some processes there. This ciliary epithelium is the one that secretes the aqueous humor. The aqueous humor is the fluid in front of the lens. The one behind the lens is called the vitreous humor. The one in front is the aqueous humor. So it secretes the aqueous humor into this region here. Other than that, we can see that it has some processes that hold and anchor the lens. Those processes anchor the lens so that the muscles that the ciliary body contain, when they contract, they regulate the shape of the lens. When the lens flattens, you're able to see far, and when the lens bulge, you're able to see near objects. So basically, the ciliary body regulates the lens, and that is important in focusing. The third one, the third component, the vascular coat, is the iris. So this is the iris, that one there. And this one, you can see here, that is now the cornea, this is the lens, that's the ciliary body. The role of the iris is that it controls the amount of light that enters the eye because it controls the size of the pupil. It is heavily pigmented, as you can see here. The pigmentation here is to prevent light from passing through there, so that it can only allow light to pass through the pupillary aperture. So histologically, the iris looks like this. This is the iris, that's the ciliary, that's the cornea, this lens. If you magnify that part, you'll see this one here. That heavily pigmented epithelium is characteristic of the iris. Deep to that, we see some loose connective tissue there. But importantly, also we see this region here that contains some smooth muscles. The smooth muscles of the iris are the ones that regulate the size of the pupil, so that the role of the iris is to control the size of the pupil, and that means it will control the amount of light that enters the eye. Let's say that in a different way by talking about the muscles of the iris, these muscles which control the size of the pupil. They are smooth muscles, and so they are involuntary, controlled by the autonomic nervous system. These smooth muscles are oriented in two orientations. We have the outer one, which is oriented in a radial manner. So we call it the outer radial muscle. This outer radial muscle of the iris, when they contract, they increase the size of the pupil. And so we call it the dilator papillae muscle. Pupillary dilatation is a function of the sympathetic nervous system. And so this part, this muscle is innervated by the sympathetic nerves. Remember from autonomic physiology that sympathetic nerves usually come from thoracic and lumbar segments. The ones that go to the eye will come from the upper thoracic segment, then they form a chain, which we call the sympathetic chain. The upper part of the chain is a swelling, which we call the superior cervical ganglion, where postganglionic sympathetic neurons come from to go to the eye. These nerves reach the eye when they form plexuses around blood vessels that will eventually go to the eye. The inner circular muscle is this one here. This one, when it contracts, it will make the pupil become narrower. So we call it constrictor papillae muscle. The constrictor papillae muscle is controlled by the parasympathetic division of the nervous system, and in particular, it's controlled by the oculomotor nerve. So the preganglionic neurons will be carried by oculomotor nerve. Then the synapse in the ciliary ganglion, which is located within the orbit. Postganglionic neurons are the ones that will reach the constrictor papillae muscle. So we've talked about the vascular layer, and we'd already talked about the fibrous layer. Before we talk about the retinal layer, I want us to say something about the refractive media of the eye. The refractive media of the eye refers to the structures that light passes through as it enters the eye. So follow that path from air. It will land onto the cornea first. After the cornea, aqueous humor. After aqueous humor, the lens, then vitreous humor. So that's the order of the structures that constitute the refractive media of the eye: cornea, aqueous humor, lens, and vitreous humor. Of those four, most of the refraction occurs at the cornea. And the reason is because at the cornea, we have interchange from gas to solid. So the medium change there will give us the highest refraction from gas to solid. However, even though most of the refraction occurs at the cornea, the refraction of the cornea, the refraction of the aqueous, and that of the vitreous are fixed. You don't have control, or rather, you cannot alter them. But the refraction offered by the lens is vital because it can be altered. And that is why then the lens is the one that is used in focusing. All right, now we can, okay, something else forgetting. Something about the chambers of the eye. It's important to talk about the chambers of the eye. So there's what we call chambers, and there's what we call segments of the eye. In terms of segments, we use the plane of the lens. So what is behind is the posterior segment, and what is in front is the anterior segment of the eye. So with that understanding, the vitreous is in the posterior segment and the aqueous is in the anterior segment. The anterior segment is further divided into chambers based on the location of the iris. And so this part here is called the anterior chamber of the aqueous humor. And this region there is called the posterior chamber of the aqueous humor. We have anterior chamber and posterior chambers of the aqueous humor. Those ones are based on the location of the iris. So if you are to trace how aqueous humor flows from the ciliary body, it's secreted into the posterior chamber. Then it flows from the posterior chamber like that through the pupil to the anterior chamber. Then from the anterior chamber, it will be absorbed into the channels which are found within the limbus, the channels within the corneoscleral junction. That is how the aqueous humor flows. Right, so now we can talk about the retinal layer. The third layer of the eye is called the retina. This is the innermost tunic of the eye, illustrated by that yellow thing there. It is the one that functions as the receptor for light. It's the photoreceptor layer. Now take note that the retina receives the second cranial nerve, the optic nerve. So that is where, that's the optic nerve, and it enters at that point. That region of the retina that receives the optic nerve is usually termed the blind spot. The reason is because at that point where the optic nerve enters or leaves what we call the optic disc, it will not have the photoreceptor cells. So the light rays that land at that position or that point cannot be detected. Therefore, we call that the blind spot. There's another region slightly up based from the blind spot that is a small depression at the center of the retina. We call it fovea centralis, or it's basically the fovea. It's a small depression in the retina. The region around that small depression has the highest concentration of rods and cones. Because that region has the highest concentration of rods and cones, is the region with the best visual acuity of the eye. That region is called the macular region. So the part of the retina around the fovea centralis is called the macula. The light rays that land at the macula usually come from the central part of the visual field. And so we can say that macular vision is basically central vision. This image captures for you that storyline. That's the fovea, and this is the macular region. That is the optic disc and the blind spot. So the rays from the central part of the visual field will land onto the macular region. Macular region is therefore the region for central vision. Now, histologically, the retina is made up of two parts. There's an outer part, which we call the pigment retina. And there's an inner part, which we call the neuroretina. So from here, all the way to there is the neuroretina. That's the inner part. This is vitreous humor. So we're starting from the vitreous humor. This is the retina up to that point. Then this thin pigmented layer there is the layer of pigment epithelium. We call it pigmented retina. Then the rest of the pigmented zone with large spaces is the choroid. And external to that, we have the sclera here, dense regular connective tissue. The neuroretina. Okay, let me start the pigment retina first. The pigment retina contain epithelial cells which are heavily pigmented, and that is why we call it the pigment epithelium. The function of the pigment epithelium is to absorb light, as we have already said, even under choroid. Apart from absorbing light to prevent reflections, the pigment retina also constitute what we call the blood retinal barrier. We've mentioned that the choroid is heavily vascularized, but we want the retina to be transparent. How do we prevent blood cells and other things from entering the retina? We must have some structural barrier. The layer of pigment epithelium offers that structural barrier, blood retinal barrier, so that blood is not allowed to enter the retina. But yes, various nutritional components may enter, but not blood tissue itself, because it will provide opacity to the retina. The neuroretina itself, this one, has several cell types. I want us to go through the cell types of the neuroretina. We have the rods and cones. These are the photoreceptor cells. Their cell bodies are located somewhere here. The processes of the photoreceptor cells come up to somewhere there. They're the ones that detect light. We have what we call the conduction cells of the retina. The conduction cells of the retina are the cells which constitute or which form part of the visual pathway. So they're the ones that conduct visual impulses from the retina to the brain. There are also two types. From the rods and cones, which are photoreceptors, we can see this neuron here, which we call the bipolar neuron. The bipolar neuron is the first order neuron in the pathway of vision. It synapses with this other region, with this other neuron, which we call the ganglion cell. The ganglion cell is the second order neuron in the pathway of vision. Now, what do you notice? The retina is not in the brain, yet we can see the first order neuron terminating within the retina itself. And the second order neuron also beginning in the retina. That's very unique. What we've been describing about sensation is that first order neuron terminates in the brainstem or spinal cord, and second order neuron is entirely within the brain or within the CNS. But we see here, second order neuron is in the retina. That tells you something about the retina. The retina is actually an extension of the central nervous system. Even embryologically, the central nervous system sending a process that comes out to go to the eye. So it's an extension of the CNS. And that is why the optic nerve itself will even be surrounded by oligodendrocytes as opposed to Schwann cells, the ones that form myelination around the optic nerve. They're oligodendrocytes, they're not Schwann cells. The rest of the peripheral neurons will have Schwann cells around them, but optic nerve surrounded by oligodendrocytes. So first order neuron, bipolar neuron, second order neuron, ganglion cells. We have association cells of the retina. Association cells of the retina consist of two of them. We have the horizontal cell and the amacrine cell. These ones link multiple bipolar neurons in the retina. They are association cells. They are interneurons. Lastly, we have the Muller cells. The Muller cells are supporting cells of the retina. They provide structural support to the retina. They are not shown in this particular image. Now, the cells of the retina exist in layers. I want us to go through the histological layers of the retina. We have 10 layers, layer 1 to 10. I'll just give you their names and what they contain. Layer 1 is what we call the layer of pigment epithelium. And so that's the one that is made up of the pigmented epithelium. Those cells that I told you form the blood retinal barrier. So that is not part of the neuroretina, but it's layer 1 of the retina. Then the rest is neuroretina. So this layer here, it's called the layer of rods and cones. You can call it the photoreceptor layer. The photoreceptor layer, or otherwise called the layer of rods and cones, contain cell processes of rods and cones. Cell processes of rods and cones. I'll skip layer 3 for a moment, and I'll take you to layer 4. Layer 4 is called the outer nuclear layer, or the external nuclear layer. The outer nuclear layer contains the cell bodies of rods and cones. That's layer 4. We've skipped layer 3. We'll come back to it later. So photoreceptors have their cell bodies here. They are processes that detect light on this end. Those photoreceptors usually synapse with the first order neurons at this region here, which we call layer 5, the outer plexiform layer. Outer plexiform layer is a site of synapse between the rods and cones and the bipolar neurons. Then we have layer 6 there. Layer 6 is what we are calling the inner nuclear layer. The inner nuclear layer contains cell bodies of 4 types of cells. It contains the cell bodies of the bipolar neurons. In this image, you can see the bipolar neurons there. It also contains the cell bodies of the amacrine cells, the cell bodies of the horizontal cells, as well as the cell bodies of the molar cells. So bipolar neurons, amacrine cells, horizontal cells, and the molar cells have their cell bodies within the inner nuclear layer. That's layer 4. Layer 5 represents the region of synapse between the first order neurons and the second order neurons in the pathway of vision. We call that one the inner plexiform layer. So I've lost count, but yeah, that's the next layer there. Okay, so if this was layer 1, pigment epithelium, layer 2, photoreceptor layer, layer 3, we skip layer 4, outer nuclear layer, layer 5, outer plexiform, layer 6 is inner nuclear. So we are now on layer 7. Layer 7 is what we call the inner plexiform layer, a point of synapse between the first order neurons and the second order neurons. Remember, first order neurons are bipolar neurons. Second order neurons are the ganglion cells. Layer 8 there is called the ganglion cell layer. The ganglion cell layer contains the cell bodies of the optic nerve, the cell bodies of the second order neurons. Layer 9 is called the nerve fiber layer. Nerve fiber layer will be somewhere there. This nerve fiber layer contains axons of the optic nerve fibers. Axons of the ganglion cells are the ones that merge to form the optic nerve. And lastly, we have layer 10. So layer 3 and layer 10 come about this way. Look at this image here. If this one here is the pigment epithelium, then this is the photoreceptor layer, processes of rods and cones. This is the outer nuclear layer containing cell bodies of rods and cones. This is the outer plexiform layer, layer 5, synapse between photoreceptors and bipolar neurons. Layer 6, inner nuclear layer containing cell bodies of 4 different types of cells. Layer 7 there, the synaptic zone between the bipolar and the ganglion cells. Layer 8 is this one, containing cell bodies of the optic nerve fibers, the ganglion cell layer. Layer 9 contains the axons of optic nerve fibers, the nerve fiber layer. Layer 10 there. Look at the molar cell, the supporting cell of the retina. It has its outer extent up to that junction, and the inner extent up to that junction. And so this constitutes layer 3, the outer limiting membrane, and layer 10, the inner limiting membrane of the retina. Outer limiting and inner limiting membrane of the retina. They are the extents of the molar cells. Those are the retinal layers and the cell types of the retina. Now we want to talk about the visual pathway. For us to talk about the visual pathway, you need some fresh mind, but I believe you're still fresh. Let's first understand some things about visual pathway. This is what we call the visual field. That refers to the regions your eyes can see. That's the visual field. We can divide that field into two. There's the left field and the right field. For example, in this image, this person can see from there all the way to here. So that's the visual field. But this is on the left side, and that's on the right side. Okay, we are working with this labeling here. If they could have labeled here right, we'll just say that it's right, but they labeled left, so let's call that left. So assume this is being imaged from below. It's an inferior view. And so that is why we are saying this is left and this is right. If it was a superior view, it would be opposite. So in this inferior view, that's the left visual field of this individual, and this is the right visual field of the same individual. We can have the visual field of each eye as well. This is the visual field of the right eye, and this is the visual field of the left eye as well. When you look at the rays that enter to each eye, some rays come from the lateral side, some rays come from the medial side of each eye. The rays which come, let's say, take for example this right eye. There are those rays which come from the lateral aspect of the eye. Those ones are considered to be temporal rays. Temporal means lateral. So this is temporal ray of the right eye. And this is nasal, means medial. Nasal ray of the right eye. Similarly, this is a nasal ray of the left eye, and this is temporal ray of the left eye. Temporal means lateral, and nasal means medial. And we can use those rays also to represent fields. So there's a temporal field and a nasal field of each eye. There's a region where the visual fields of each eye overlap. That region where the visual fields of both eyes overlap is called the binocular visual field. It refers to the region that both eyes can see. Binocular visual field. Now, let's advance that a bit in terms of complexity. And let's talk about how each of the eyes receive rays from the visual field. Let's start with the right eye. We notice that yes, the right eye has a temporal field in green and the nasal field in the other color. The rays which come from the nasal field of the right eye, we can see they land on the lateral aspect of the retina of that eye. Yes, they came from the middle aspect, but they land to the lateral aspect because rays interchange at the pupil. This is physics. So there's some inversion at the pupil. So here it's a lateral inversion. Rays from the middle aspect land onto the lateral aspect of the retina. Rays from the lateral aspect of the field land on the middle aspect of the retina. And that applies for both right eye as well as left eye. So in this case, the green is now from nasal field of the left eye. They land onto the temporal field of that eye. And the rays from the temporal field land onto the nasal field. So that statement, I want you to understand it well, that the rays to each eye can be named as either coming from temporal field or nasal field. That is true. For the right eye here, the green is temporal and that other color is nasal. For the left eye here, the green is nasal and that other color is temporal. What do we notice then? We can also name the parts of the retina as medial or lateral for the sake of simplicity. So lateral is temporal and medial is nasal. For each eye, this is nasal retina and that's temporal retina. This is nasal retina and that's temporal retina. So what happened? I want you to take a second and look at that. Where do temporal rays land on the retina? And where do nasal rays land on the retina? Take a second and have captured that very well. So I hope you've noticed. We can use this other image also to help us in that. This is nasal. Sorry, this is temporal field of this eye. Right now we are having a superior view. This is now view from the top. So this is now left, this is right. This is a superior view. So for this left eye, this is temporal field and this is nasal field. For this right eye, this is temporal field and that's nasal field. You notice that the rays that come from the visual fields will pass through the pupil and become inverted. And for that reason, temporal rays will land onto the nasal retina and nasal rays will land onto the temporal retina. Pick that one on this slide. Temporal rays land onto the nasal retina and nasal rays land onto the temporal retina. Now let's advance that a bit. We are escalating. The retina will detect the light rays that land on it. And the information from the retina will then leave the retina to go to the brain. Within the retina, we noted that there is already first order neurons there, bipolar neurons. We also noted that we have second order neurons already there as well, the ganglion cells. So the axons of ganglion cells come out from the retina and are the ones that constitute the optic nerve. So from the photoreceptors, you'll have the bipolar neurons, then ganglion cells. The axons of ganglion cells are the optic nerve, and that's what we see here and there. These optic nerve fibers are second order neurons, and as we said, second order neurons usually decussate. So the point of decussation of the optic nerve fibers is called the optic chiasma. Usually somewhere just in front of the pituitary gland, but behind both eyes. It's just a point of decussation, so there's no synapsing there. Not all fibers of the optic nerve decussate at the chiasma. Only a few fibers, or only some fibers decussate. Beyond the optic chiasma, we still have fibers which came from the optic nerve. There are still fibers of second order neurons. That one constitutes what we call the optic tract. So beyond the optic chiasma, we have what you call the optic tract. Remember, there are still axons of second order neurons, but now carrying information from both eyes, because some fibers of optic nerve did not decussate, and some fibers of the optic nerve decussated. So optic tract carry information from both eyes. Optic nerve carry information only from one eye. These fibers within the optic tract are designated for the thalamus. The region of the thalamus that receive the second order neurons for vision is called the lateral geniculate body. You can call it the lateral geniculate nucleus of thalamus. Just like hearing and vestibular function, visual input does not just go to the thalamus and cerebral cortex only. It may also go to other regions. Those other regions that receive the fibers of optic tract can be termed as extrageniculate projections of the optic tract. And I can name for you a few of them. I'll name for you 3. Some fibers of the optic tract will go to the superior colliculus of midbrain. So from the optic tract, they'll go to the superior colliculus of midbrain. It's not shown there. The ones that go to the superior colliculus of midbrain are the ones which they mediate visual reflexes. This thing of you see light and you turn your head towards the direction of light. That's a visual reflex. The second extrageniculate projection is the suprachiasmatic nucleus of the hypothalamus, the one labeled there. Suprachiasmatic nucleus of the hypothalamus. The projection to the hypothalamus is the one the brain uses to know it is daytime and it's nighttime based on the amount of light that enters. So that one helped to set the biological clock. The suprachiasmatic nucleus of hypothalamus is therefore connected to the pineal gland, which usually is the one that set our clock. The third projection from the optic tract goes to, again, another region within the midbrain. We call it pretectal nucleus. The pretectal nucleus is the one that controls the pupillary light reflexes. When you shine light on one eye, that pupil constricts. But also the other pupil constricts as well. So we talk of direct and consensual pupillary light reflexes. That is when you shine light onto the eye and the pupil constricts. Don't confuse a light reflex with a visual reflex. So pretectal nucleus mediates light reflexes, both direct and consensual types. Superior colliculus mediate visual reflexes. Suprachiasmatic nucleus, in collaboration with the pineal body, control the circadian rhythm, biological clock. So that is why we must have extrageniculate projections of the optic tract. Information from the eye must go to all other regions, those other regions. But the one that go to the thalamus is the one that is designated for perception. So from the thalamus, what are we going to have? It will send us now with the third order neurons for vision. The axons of the third order neurons for vision come from the thalamus all the way to the primary visual cortex. As they pass through, they'll either pass through the temporal lobe inferiorly or parietal lobe superiorly to reach the banks of the calcarine sulcus. We call those axons of third order neurons optic radiation. So fibers of optic radiation can either take the superior route to reach the banks of calcarine sulcus. So those ones will go to the upper bank. Or they can take the inferior route to reach the lower bank of the calcarine sulcus. And that will mean they'll take the temporal route. All in all, they'll terminate at the primary visual cortex, area number 17, the banks of the calcarine sulcus. Take note, At the primary visual cortex, the information from the visual field has a topographic representation as well. The region that represents central vision, which means the rays that landed at the macula, the information of the macula land somewhere there at the posterior pole of the primary visual cortex. And then progressively we move from the central part of the visual field to the peripheral part of the visual field. So the information that is landing on the anterior aspects of the calcarine sulcus, remember it's in the occipital lobe, will be information from the most peripheral parts of the visual field. And the information that land at the posterior pole will be information that come from the central part of the visual field. We've said that the right hemisphere of the brain controls the left of the body, and the left hemisphere of the brain controls the right of the body, and that's important. That is, we know that. And we know that this is achieved by neurons decasseting. However, at the optic chiasma, we've just noted that not all the axons of optic nerve decassate at the chiasma. There are only some fibers that decassate and others do not decassate. So back to that concept, which fibers actually decassate and why should they be the ones that decassate? Look at that image again as we answer that question. So here it's an inferior view. So this is right, this is left. This is temporal field of the right eye. Those rays have landed on the nasal field of the right eye. So remember, right field, right eye. That fiber has not yet decassated. It is on the right side. It's coming from the right side of the field. It has landed onto the right eye. So no decassation yet, whatever decassation will mean at this point. No crossing over. So the information from the nasal retina, which represents temporal field, will be carried by optic nerve fibers, the ones that are going to decassate. At the optic chiasma, the fibers that decassate are the optic nerve fibers from the nasal retina. Now let's look at this one. This is the nasal field of the right eye. So this nasal field of the right eye, the information is landing onto the temporal retina. Now take note, the nasal field to each eye is actually from the opposite side. What I mean is this. This is the right eye, but these rays are actually coming from the left visual field. So they're coming from the left visual field and they're landing onto the right eye. Decassation has occurred, even if it is in quotes. Crossing over has taken place. And because those ones have crossed over, they do not need to cross over again. For that reason, the optic nerve fibers from the temporal retina will pass through the chiasma without decassation. So they come from the right side, they'll maintain that side. But optic nerve fibers from the nasal retina have to decassate because the information they're having is on the same side as that of the eye. So in summary, when you talk about right side controlling the left side, for visual pathway, the left hemisphere of the brain has information regarding the right visual field. It's about the visual fields. It's not about the eyes. It's about the visual field. The information from the right visual field, represented by green here, is directed to the left hemisphere, as you can see. Information coming from the left visual field, represented by what I want to call purple here, I might be wrong. That information goes to the opposite side. In this case, it coming from the left field, it will land on the right visual cortex. It is decussation of visual fields. Having said so, I'll be giving you this, so you can get this quite often. Those dotted lines simply mean we can put many places. In this case, A would mean the optic nerve, the right optic nerve. Now this is a superior view again, so that's the right optic nerve. B would be perhaps the level of the optic chiasma. C would be perhaps the level of the optic tract, as you can see. And you can think about what happens in the others, different parts of the optic radiation and visual cortex as well. So let's put, for example, a lesion of the pathway at A. What will be the effect of injuring the right optic nerve? Will you lose vision on both eyes, or you'll only lose vision on the ipsilateral eye, which means now we've affected right optic nerve, it is the right optic nerve that will lose vision. Or will you lose vision on the contralateral eye? To mean if you've injured the right optic nerve, the left eye is the one that's not going to see. Or will there be no loss of vision? That despite injuring the right optic nerve, this person will still be able to see. If you injure the right optic nerve, it means that information from the right eye cannot go to the brain. Therefore, you'll have total blindness of the right eye. So the name of the specific condition is total blindness, total anopia of the ipsilateral eye, the same side. How about at part B? If you cut off the optic chiasma fibers in the manner shown in B, then you realize that you are targeting the decussating fibers of the optic chiasma, but you are sparing the non-decussating fibers of the optic chiasma. So it means that we are affecting information from both eyes. And so both eyes are going to be affected, first of all. But how are both eyes affected? Let's see. These are the fibers from the nasoretina of both eyes. The nasoretina has information from the temporal field of each eye. So this is temporal field of the right eye. This is temporal field of the left eye. If I cut off optic chiasma fibers in the manner shown in B, I will prevent information from the temporal field of the right eye and temporal field of the left eye from reaching the brain. I'll therefore not be able to see temporal fields of both eyes. So first, both eyes are affected, but how? You lose temporal vision on both eyes. We call that bitemporal hemianopia. So that's the name given to the specific condition, bitemporal hemianopia. Bi to mean both sides, bitemporal, so both temporal fields. Hemi means that we're losing half and sparing half. In this case, we are losing temporal, we are sparing nasal fields of each eye. So it's a hemianopia. Let's try one last one. Injury at the region labeled C. We are affecting the right optic tract. The right optic tract carry information from the right eye and also information from the left eye. And so if I injure optic tract, I will affect both eyes as well. But how are both eyes affected? We can see this fiber here. If we trace it back, it is from the temporal retina of the ipsilateral eye, which means it is carrying nasal field of the ipsilateral eye. So that one is affected. If you trace this other one, it's coming from the nasal field of the contralateral eye, which means, sorry, it's coming from the nasal retina of the contralateral eye, which means coming from the temporal field of the contralateral eye. So I'm losing the temporal field of contralateral eye and nasal field of the ipsilateral eye. If I lose nasal field of one eye and temporal field of the other eye, in a nutshell, I have lost one whole visual field. And in this case, the opposite visual field. If this is the right optic nerve, then this is the left visual field. This is the right visual field. If this is the right optic tract, they should be tract, not nerve. The right optic tract carry information from the contralateral visual field. So if I injure the optic tract, I lose a whole visual field. If I injure the right one, I lose the left field. If I injure the left one, I lose the right field. So the term given is contralateral homonymous hemianopia. Contralateral homonymous hemianopia. So hemianopia, you understand why hemianopia, half lost, half not lost. Homonymous means that we've lost one whole visual field. When you affect one visual field, you don't affect both visual fields. We call it homonymous hemianopia. To distinguish it from lesions that affect both visual fields at the same time, which are called heteronymous hemianopia. So homonymous means that you've affected only one visual field. Now we call it contralateral because the opposite side. So contralateral homonymous hemianopia. Great, so I've guided you on how to think through visual pathway lesions on the first three, so the others you can do at your own time. Okay, this image shows you those lesions that I was describing for you. So the first one is bitemporal hemianopia. The second one has a unique name, you'll find it. The third one is homonymous hemianopia. As you can see there, you're losing one visual field. There are others which have interesting names. When you see those ones with dots at the center, we call that macular sparing. And you'll have to know why do you have macular sparing then as you go towards the visual cortex. Let's talk about extraocular muscles. These are muscles that are found outside the eyeball. There are 7 in total. 6 of them move the eye. 1 of them moves the upper eyelid. In terms of their names, they come from around the apex of the orbit, most of them, and they run anteriorly, most of them. They just run anteriorly like that to the eye. So there are 4 that run straight to the eye. We call them recti muscles. 1 on top, superior rectus, 1 below, inferior rectus, 1 medially, medial rectus, and 1 laterally, lateral rectus. If the superior rectus contract this muscle here, it will pull the upper part of the sclera backwards, and that will make the pupil face up. So superior rectus makes the pupil face up. We call that elevation. Superior rectus elevates the eye. Similarly, the inferior rectus comes from orbital apex and insert on the sclera on the lower part of the eyeball. So if it contracts, it will pull the sclera on the lower part backwards, and that will make the pupil face down. So inferior rectus depresses the eye. Lateral rectus will pull the sclera laterally, and that will make the pupil face away from the center. Lateral rectus abducts the eye, and medial rectus will then adduct the eye. So those are the 4 recti muscles and what they do, the primary action they do. I will revisit superior and inferior rectors again shortly to add other functions to them. But for now, we've captured those functions we've stated for each muscle. There are 2 oblique muscles, superior oblique, which is this one. It comes from here, orbital apex, goes on the middle aspect, turn at a pulley system, then go reverse and insert on the sclera, upper part of the sclera, posteriorly and superiorly in that manner. So if superior oblique contracts, how will it move the eye? It will pull the posterior aspect of the sclera medially because this part will pull that way. And just like the steering wheel of a car, if you pull the posterior part this way, the other part goes that way. So the superior oblique muscle will also cause abduction of the eye. However, suppose this eye is already adducted, to mean that this pupil is facing this direction. And so the visual axis of this right eye is along the axis of pull of the superior oblique muscle. If the eye is already adducted and superior oblique muscle contracts, it will pull the upper part of the sclera forwards, and that will make the pupil face down. So the second action we are attributing to superior oblique is that superior oblique depresses the eye. Remember, it causes abduction of the eye. Now I'm adding, it also depresses the eye. The third action I want to add to superior oblique is this one. Suppose this eye is already abducted, which means this pupil is facing here, and then the superior oblique contracts. It will make the upper part of the sclera go medially and the lower part of the sclera go laterally, but the axis of that will be an anteroposterior axis. And so that will make the eye rotate. If the eye rotates in such a way that the upper part goes medially, we call that intorsion. If the opposite happens, we call that extorsion. So 3 actions for superior oblique. It depresses the eye, it causes intorsion, and it causes abduction of the eye. Let's now think through the inferior oblique. The inferior oblique begins from somewhere there, just the margin of the eye there, and go to insert into the eye, the lower part of the eye, but again posteriorly. So if the eye is already abducted and inferior oblique contracts, it will also rotate just like superior oblique, but it will rotate in the opposite direction. So inferior oblique causes extorsion of the eye. If this eye is already adducted, which means that the pupil is facing the same axis of pull like that of the inferior oblique, then the inferior oblique will pull the lower part of the sclera forwards. And so the upper part, it will pull the lower part of the sclera forwards. And so the pupil will face upwards. Inferior oblique elevates the eye. That again is opposite the action of superior oblique. Now the third one is important to capture. It is not an opposite, but the same as what superior oblique was also doing. Because we see that both of them are inserted posteriorly on the eye. If either superior oblique or inferior oblique contracts, they'll pull the posterior part of the eye medially, and that means that the pupil go laterally. Both inferior oblique and superior oblique abduct the eye. So that they share that role, but the other actions are opposite one another. Those are the oblique muscles. So before I move on from the muscles that move the eye, I hope you realize, therefore, that the eye can move in 3 axes. If I take this mouse to be the eye, and so this is the pupil. When the pupil faces up, we call that elevation. When the pupil faces down, we call that depression. Elevation and depression occurs through a transverse axis, a mediolateral axis. That's the axis of elevation and depression. So an axis that cutting across like this will be the plane, the axis of elevation and depression. But there's also another vertical axis. The vertical axis passes through like that. The vertical axis is where adduction and abduction of the eye take place. So when this pupil faces medially, that is adduction, and then the pupil faces laterally, that is abduction. The last one is the anteroposterior axis of the eye. So the plane this way, anteroposterior axis is for rotation of the eye. The eye can rotate medially, intorsion, and laterally extorsion. Of course, in humans, we really don't need that movement, but yes, it is there. The last extraocular muscle is the one that has been cut here. We call it levator palpebro-superioris. The levator palpebro-superioris has 2 parts. The posterior bulky part of it is made up of skeletal muscles, and so it's voluntary. The anterior-most part of it, which is within actually the upper eyelid, has smooth muscles, and it is involuntary. We call that part the muscle of Muller, the involuntary part. As the name suggests, when that muscle contracts, it will elevate the upper eyelid. So this is the one that makes your upper eyelid to open up. In terms of their nerve supply, we use this thing to help us remember how the extraocular muscles are innervated. But of course, you've done this under neuroanatomy series. So LR here stands for lateral rectus, and 6 stands for the 6th cranial nerve. This is to mean that lateral rectus is innervated by the abducens nerve. It is actually for that reason that the nerve is called abducens. You know, lateral rectus causes abduction, so it abducts the eye. SO stands for superior oblique. Superior oblique is innervated by the 4th cranial nerve, which we call the trochlear nerve. So superior oblique is innervated by the trochlear nerve. All the other extraocular muscles enjoy innervation by the oculomotor nerve. So that is how we remember the innervation of the extraocular muscles. I told you that we'll revisit the actions of the superior and the inferior recti. So let me say it before we move from this slide. If the superior rectus contracts, it will pull the upper part of the sclera posteriorly, and so the pupil will face upward, that is elevation. Inferior rectus will cause depression. Now that is more practical if that eye is already abducted, which means that the pupil is facing that direction, and so along the axis of pull of the superior and inferior rectus. However, if this pupil was facing this direction, so the eye is adducted, and the superior and inferior recti contract, they may not elevate and depress the eye, but they'll cause rotation, intorsion, and extorsion. I want to give you some exercise. So we are presented with somebody here who has a problem with one of the eyes. The question I want to pose to you is the one displayed there. Which cranial nerve is injured so that that eye can be in that position? If you understand the anatomy of the extraocular muscles and how their actions and innervation, then this should not be a difficult thing. So when you look at this one, the eye affected is the right eye. It is important that you determine which eye you're focusing on first. Then the next thing you ask yourself is, how is that eye affected? In this particular lady, the eye is facing medially, which means if it is about paralysis of some muscles, then the muscle that is paralyzed is the muscle that is supposed to be taking it laterally. And because of the absence of that action, now the eye has a dominant medial deviation. The eye is predominantly adducted because you've lost a muscle that should cause abduction. You've paralyzed that muscle. And so the answer, therefore, should be really straightforward. This is abducens nerve injury. So we've only eliminated abduction. Let's try with this one. So in this particular second case, again, the eye of concern is the right eye. We can see that the eye is adducted, but it is also elevated. The eye is facing medially and upwards. They have a medial upward squint. Think through one muscle that can be lost so that you have those two. The muscle will be superior oblique. Superior oblique usually causes depression and abduction. And so if it is paralyzed, you lose abduction and you lose depression. The eye becomes adducted and elevated. And so the muscle is superior oblique and the nerve is trochlear. The third case is oculomotor nerve injury. What we notice is that the eye is abducted predominantly. And that means you've lost a muscle that causes adduction. That should be medial rectus, innervated by oculomotor nerve. So they are really straightforward. Now, for oculomotor nerve injury, there's something else I wanted to pick. This diagram captures for you exactly what happens if a patient has oculomotor nerve injury. So the eye is usually abducted because you've lost medial rectus, but it also has a downward gaze because we've also paralyzed the inferior oblique, which causes elevation. You can still argue that you've affected the recti, but remember both of them are affected, superior and inferior, so that one cancels one another. The pupil is also dilated, and the reason why the pupil is dilated is very important to pick. If somebody has oculomotor nerve injury, they'll have a downward outward gaze, and I've given you the reason, but they'll also have pupillary dilatation. The reason is because oculomotor is the one that provides parasympathetic nerve supply to the eye, which causes pupillary constriction. So if it's injured, the pupil will be dilated. And lastly, oculomotor nerve injury will also present with ptosis, drooping of the upper eyelid. The reason the upper eyelid drops is because it was again paralyzed the levator palpebral superioris, which causes elevation. So that's how we work around the lesions of the extraocular muscles. They're not hard, but you must first make sense out of what they do for you to be able to pick the type of squints and the nerves related to those squints. All right, let's finish the story with this last slide on the lacrimal apparatus. Tears is produced by the lacrimal gland, which is found in the upper outer region of the orbit. Upper outer region of the orbit. The ducts from the lacrimal gland will direct tears to the anterior part of the eye. And your eyelids, as they close and they open, they help to spread the tears. So there'll be a film of tears in front of your eyes, but because of gravity, much of that film will be on the lower part between the eye and the lower eyelid. So that pool of tears is what we call the lacrimal lake. From the lacrimal lake, on the middle aspect, there are usually some two tiny openings, which we call the lacrimal puncta, that drain the tears. Superior and inferior lacrimal puncta take tears through these tiny channels, which we call the lacrimal canaliculi. So you have the inferior and the superior lacrimal canaliculus. The two canaliculi meet in this large region there within the bones. You can't see it from outside. We call that the lacrimal sac. From the lacrimal sac, there's a channel that takes tears from that sac all the way to the nose. That will open in the inferior nasal meatus. That's below the inferior nasal turbinate. So that's the meatus. So that channel that takes tears to that region is called the nasolacrimal duct. And it will open in the inferior nasal meatus. So that's the path followed by tears from the lacrimal gland all the way to your nose. That's why sometimes when someone is crying, they'll also be passing something through their nose. All right, now that marks the end of the lecture on the visual system, and of course on the lecture on the spatial sensations as well. Thank you very much.